Welcome to our special program today, where we're going to be talking about newer medications for people with diabetes.
There's so much to talk about, new medications. I will be getting all the questions that you guys send as the program's on here, so we'll come around to that. So let's just jump into medications.
Yeah, I'll just start off by saying that, Jeremy's a little younger than I am, but in the past decade, when Jeremy was still training, since we've had 10 years of developing, believe it or not, over 44 medications approved for people with type 2 diabetes. Now, some of those are in the same category, so they're similar, but they're made by different companies. But that's a lot. And the other thing is that a lot of people are not taking advantage of them, and for a lot of reasons. They don't know about them, their caregivers don't know about them, and that's why these programs are so important.
Yeah, I was just gonna say, I think there's been a real frame shift too. I mean, like, whenever I see somebody with type 2 diabetes, it often comes off, hey, how can I get off of these medications? It seems to be, something that people really want to do. But really, with the advent of some of these newer things, I mean, there's an opportunity with these medications in terms of not just improving your blood sugars, but reducing weight, reducing heart disease, actually making people live longer, having less all-cause mortality. I mean, it's really just kind of crazy what these new medications can do. And if you have type 2 diabetes, it's worth talking about also that the kind of treatment algorithm is that we add medications. You start with one medication, you have to add a second, add a third, and people can kind of think, gosh, I must be getting sicker, my diabetes is getting worse. And diabetes does get, more difficult to control over time. So it doesn't mean that you're failing. It just means that you should know the best options for the medications that you can be on, talk to your healthcare provider. And some of these medications, I am not kidding, I'm jealous that type 2s can take these things because they are so efficacious with actually pretty, very safe, minimal side effect.
Yeah, that is so true. That I want to say that the thing that really changed the way we treat type 2 diabetes is a whole series of studies that us doctors call CVOTs, cardiovascular outcome trials. Because years ago, the FDA was concerned that some of these new drugs may have harmful effects on the heart. And what happened was everything was opposite, that they showed these benefits: heart attacks, strokes, heart failure, and even discovering that some of these new medications, which we're going to talk about, protect the kidney. So I really think that things have turned around since that point. Yeah. And one thing I want to come back to that you mentioned is, after we go through some of these new drugs, we should talk about the American Diabetes Association treatment algorithm that doctors follow when they decide which medications to give to all of you folks with type 2 diabetes.
Yeah, I think we could mention, real quickly, kind of how that works, broad strokes. So when they're diagnosed with type 2, sometimes we can get away with diet and exercise. People need to go on an initial therapy. The majority of the time, the first drug we use is Metformin. It's a drug that's been around for a zillion years. It's very efficacious, very safe, very cheap. And then after that, we are really using these new class of medications, SGLT2 inhibitors and GLP-1 receptor agonists. That is a mouthful, but let's talk about those, because if you do have type 2, Metformin, and then you should really be on one of these drugs unless there's some compelling reason not to be, which is becoming harder and harder to find. So
you guys have to be your own advocate too.
Yeah. So do you want to pick one? And
Sure.
in?
I think it's fair to say, let's pick the GLP-1 receptor agonist first. They are injectable. And, we do have the oral SGLT2s, but these have been out since, ready for this, 2006. And once again, their uptake, they follow the prescribing practices of doctors, and they just inching. It wasn't only until a few years ago when one of the GLP-1 showed a surprising reduction in heart disease. And so there's several out there on the market, and I think the ones that you've seen the commercials on are Trulicity, the easy to inject GLP-1. You've heard of it's Mac. You've heard of them. There's also Bydureon. There's Victoza, and I believe there's a couple more. But that is testament to the fact that when a pharmaceutical company discovers a drug that really helps people, then they all want to get in on the game. And thank goodness, because competition is good. It doesn't help the commercial quality because they're all pretty goofy to me. But these drugs, why don't you talk about, I think, some of the non-glucose effects?
Yeah, well, so first of all, these are injectables, and most of them now are, once a week, which, it's just, get over it, to be honest. It's not that hard to take these injections. They're very easy, like these kind of auto injector pens. A lot of times you don't even have to see the needle. And they have a lot of effects. They lower glucose, and they make people feel less hungry too. So they actually end up eating less and losing weight. So a lot of these medications now will have kind of a lower dose that's indicated for diabetes and a higher dose that's indicated for actually weight loss or obesity. And the weight loss that we're getting with these drugs now are getting to be on par with what you could get from bariatric surgery. I mean, actually having the whole gastric bypass and everything, which if you can avoid that, you actually want to, because it's a big surgery. There's a lot that goes into it. So once a week drugs, lower blood sugars, help reduce weight, significant weight loss. And then yes, now showing that they have benefits in terms of reducing cardiovascular disease and kidney disease. So like the benefits are really, really profound. The side effects, which everybody always wants to know, what's the catch?
Yeah.
These drugs, because they make you feel full, that can make you feel nauseated. That real intense feeling of, gosh, I ate too much. Can make you feel
Like on
nauseous.
Thanksgiving.
Yeah, for sure.
Just when you eat too much.
Nauseous, people can even vomit. The good news is that this tends to go away. If about 30% or so of people get nausea when they start it. I mean, 70% won't have any problems with that. But if you stick with it for 3-4 weeks, it tends to go away, and it is worth trying to tough it out, because if you can get over that initial hump, then it can really be smooth sailing. But those first couple of weeks can be a little rough.
Yeah, I have to give you a little bit of grief, Jeremy.
Okay.
You told the group, get over it. Now, you and I have been taking shots since we were 15.
Yeah.
And if you take that attitude, it's not going to work.
Okay, get over it.
No, but let me just add on a couple things. Jeremy did mention heart and kidney disease, and they are primarily reducing, they meaning GLP-1 receptor agonists, reducing heart attacks and strokes. We're going to get to the SGLT2s, which do primarily heart failure. Heart attacks and strokes, that's big. Mm-hmm. And there is some data to show that they're improving kidney function as well, and that we're going to get to the SGLT2s. So once again, these drugs are once a week. And the thing about the nausea is this, you and I prescribe them in clinic, and you start with the lowest dose, and sometimes you go lower than the lowest dose, because some of these pens, you can dial up the lowest dose, so you can go halfway up to the lowest dose. And the best dose is the dose that induces satiety and reduces your appetite, but does not cause nausea. Yeah. And as Jeremy said, the nausea does go away, so there's no rush. You've had type 2 for probably a long time. You've had, obesity or being overweight for a long time. Just take it slow. A lot of people crank up too quickly, and then all of a sudden they get nauseated. Then they turn off to the drug, and they are getting more accessible. Yeah. And I'll tell you what, Jeremy's right. The weight loss for the higher dose, like Trulicity, for example, it was originally 0.75 and then 150. Now it's like, 3 and 4.5. So there's I'm using different units, so I'm sorry to confuse you, but 0.75, 1.5, 3, and 4.5.
Let you find it. Yeah, you got it.
And you know what? When you look at all the weight loss drugs out there, like the uppers, the amphetamine-like drugs that are approved for weight loss, the recidivism rate.
Oh, good word.
I know. Gaining the weight back is so high. They got tons of side effects. They're dangerous on your heart. You're taking a drug that will prevent the progression of your type 2 diabetes, heart and kidney, weight, and everything else that goes along with that. Yeah. What happens when you lose weight? Your heartburn gets better.
Yeah, you go on more dates.
And you know what? There's a thing called fatty liver disease. Yeah. It helps that as well, and that could be a serious condition. So, it's an amazing class of drugs. And
I want to mention too, because you gave me a hard time about the injection. There
just get over it.
There actually is now one oral GLP-1 drug that you can take by mouth. It's a once a day pill. It has some issues that, in order to get it absorbed, you have to take it completely on an empty stomach, not eating anything for 30 minutes. So sometimes that can be a little bit of a pain. To be honest, I think once a week an injection I feel better about getting the more consistent dose, et cetera. But there is a relatively new oral GLP-1 if you're absolutely averse to needles.
It's called Rybelsus, and you've seen commercials now. And you know what's nice? There's choices. Yeah. so we can pick which one that fits the best in your lifestyle.
So let's talk about the SGLT2s.
All right.
So again, it's alphabet soup. You don't have to worry about what that means. But basically what these drugs do is they're once a day pills, and these are drugs like Jardiance, Farxiga, Invokana, Steglatro, all these different names, that basically block to some degree the kidney's ability to reabsorb glucose, so you pee out sugar. And this is about 100 milligrams or so a day. So when you pee out that much sugar, your A1C, your blood sugars come down, and you're also peeing out calories, so people lose weight. And then again, we're finding out with now these larger studies that the results in terms of reducing heart disease, particularly heart failure, has just been astounding in terms of really preventing cardiac death, all-cause mortality, and then surprisingly, kidney disease in a good way. When people hear I'm peeing out sugar, isn't that a bad thing for the kidneys? Not only is it not a bad thing, it is a very good thing in terms of preventing kidney failure, preventing dialysis, preventing kidney transplant for people not just with diabetes, but without diabetes now also. Yeah. These drugs have just you can't oversell what a breakthrough both of these classes of medications have been. And the results of these trials kind of keep piling up in terms of additional beneficial effects. And the last thing I'll say is that the side effect profile of these is very safe. So people can notice a little bit of mycotic infections, basically fungal infections when they start.
Just get over that.
Stop. But that tends, it does tend to go away when blood sugars improve. But otherwise, you don't really hear much about side effects for these medications.
So, most of the data recently is Jardiance and Farxiga. And you're right. The positive data is piling up. Well, let me just say this, that the thing about mycotic infections, which is just basically a yeast infection, it primarily occurs in women, and it occurs in men who aren't circumcised. And if your glucose control is really bad, that means you're going to be peeing out more sugar. So you might be a little bit more at risk, but it occurs at a very low rate. And so once your glucose control gets better, your risk goes down and down and down. And some people get a little bit more thirst in the morning because you're peeing out all the sugar that has to go with some fluid. So if your sugar is really high, if your A1C is high, you might notice a little bit of being thirsty in the morning. That's why we recommend just taking it first thing in the morning. And you know what's great? You can take these along with the GLP-1.
Well, I was just going to say, the combination of these two, significant weight loss, and you get all these cardiovascular and kidney benefits, because we should really back up and say, why do we control blood sugars in the first place? We're not just trying to get a perfect number, a perfect A1C. We want to control blood sugars to keep people living a long and healthy life. And a part of that, particularly with diabetes, is to avoid heart disease and kidney disease. Heart disease is the #1 killer of Americans in general. And then if you have diabetes, that risk goes significantly up. That's, not to be too morbid, but that's the reason that everybody with diabetes is most likely to die, type 1s and type 2s. So now having
even
drugs,
us?
Yeah, even us type 1s. So now we have drugs that obviously can control your blood sugars, but have these this hard data that it's keeping people alive and healthy is fantastic.
Yeah, and I think I'll just emphasize Jeremy's point that, 50%, the main cause of passing away for all Americans is heart disease, about 50% of the Americans. But if you have type 2 diabetes, it's 80%. And then you can say, for years and years, we never talked about type 1 diabetes. What's the main cause of type 1 diabetes passing away?
Cardiovascular disease.
Cardiovascular disease. And that's the area of Jeremy's research at UCSD. And so it is so important. And let me just say something else about heart attacks and heart failure. When you have a heart attack, part of your muscle dies in your heart, and it can't pump out blood normally. And that tissue doesn't come back. So key is prevention. And if you have had a heart attack, prevent the second heart attack. And congestive heart failure is when your heart can't pump blood well enough, goes into your lungs, you get swelling of your ankles, you get short of breath, and that's a really ominous sign too. So if any of you have had one episode of congestive heart failure, you got to do everything you can to prevent the second.
Right.
And the data on people with kidney disease is amazing. And as Jeremy said, this is really important. The FDA gave approval for these medications to be used with or without type 2 diabetes. And the ADA algorithm that doctors look at and follow if you have multiple risk factors for heart disease, which is most people with type 2, a lot of folks with type 1, but if we're focused on type 2, then you should start off with either an SGLT2 inhibitor or a GLP-1 receptor agonist.
Yeah.
So if you have heart failure and kidney disease, SGLT2, heart attacks and strokes, GLP-1, it's not usually that cut and dry. And then if your glucose isn't at goal, you go to the other one, no matter which one you started first. So, you know what? Just doing this show and tell has got me all pumped about how lucky we are to have these medications. It's changed everything.
It really has. And we're not specifically talking about it, but I feel like we should give a nod to blood pressure and cholesterol control, which are still very, very important. And so everybody with diabetes needs to have that on their checklist to talk to their provider. Is my blood pressure at goal? Is my cholesterol at goal? Do not forget to address those, because those dictate heart disease even more than blood sugar. So stay on top of that. Let's just say real quick with type 1s, because for all of us type 1s that are listening out there, they're thinking, gosh, these drugs sound fantastic. What's going on? These drugs, the broad category, GLP-1 and SGLT2s, have both been tested in patients with type 1 diabetes in large clinical trials. Both of them work in the sense of lowering blood sugars, like lower A1C 0.3, 0.4%, nothing super dramatic, but people tend to lose weight, use less insulin, all these good things.
Time and range
improves. So there was a lot of excitement about getting these drugs approved for type 1 diabetes. However, the SGLT2 drugs, the ones that make you pee out glucose, are associated with increased risk of diabetic ketoacidosis in type 1s. So they're not approved in the United States.
You should explain that a little more, because people with type 2 can have it. It's pretty rare.
It's pretty rare.
Because it's a big word. If you have type 2, you probably haven't heard of that.
So it basically is a situation when your body's not getting enough insulin. And what happens in type 1s is that you might not be getting insulin, your pump falls out, something like that. And instead your blood sugar is going to 350, and you know that something's wrong, you're not getting insulin. If you're peeing out sugar, your blood sugars can stay kind of normal, and you might not know that you're getting into a problem with ketones. So you lose your kind of biomarker or your insight into the fact that you're not getting insulin. So these drugs do have an increased risk in type 1s. There's no two ways about it. Type 1s can take it off label, but you have to be very careful, monitor your ketones, knowing what the symptoms are, etc. For the GLP-1s, it's a little bit of a sadder story in that, again, there's benefits in type 1s, but basically the companies haven't decided to pursue them. There was a little bit of increased risk of hypoglycemia. I think honestly that's manageable. Some of these companies are still looking to explore it in type 1s. But again, there's all these caveats, because what if you were an obese type 1? Sometimes you can use these specifically for weight loss because they are approved for weight loss. And what about if you're a type 1 with kidney disease? Like, do you want to talk about that at all?
Yeah, for sure. The data is so strong for reducing kidney dysfunction in type 2s that people have thought about this quite a bit, and they've been smaller studies, but the cause of kidney damage in type 2 is the same as type 1s, pretty much. And so we are prescribing these SGLT2s in people with type 1 diabetes. And full disclosure, I have type 1, obviously, and I have kidney dysfunction, what they call chronic kidney disease stage 3, which is right in the middle. And I spoke to my nephrologist, and I am taking Farxiga right now.
Yeah. So one of these questions came up, what does it mean to be off-label? If it's not approved for type 1, it's off-label. Practically speaking, it means that it's very hard to get it covered through insurance because it hasn't gotten the official indication through the FDA. We mentioned that there's, potentially increased risks. Doctors still can prescribe it, but there has to be a real honest conversation about the risks, the benefits, documenting all that. The patient knows that, the doctor knows that. And then it's to kind of cross your fingers to get it through insurance. But it means that it hasn't gone through the clinical trials. It hasn't been approved by the FDA for that specific disease.
Yeah, and doctors get really scared. Off-label, I'm going to get sued. But the definition really is a doctor can use any medication they want on or off-label if they feel it's safe and effective for that patient. Mm-hmm. So, sometimes you may have to educate your doctor.
So anything else you want to do, or do you have any questions? Or
I think let's go through and then we can add stuff in as we go.
I think there's some good questions. So we kind of address this. Can you take both SGLT2s and GLP-1s together, and are the benefits additive? So we know the weight loss benefits are additive. I don't think there's been any long-term cardiovascular outcome trials to see if those benefits add up. I would assume that they do, but we don't really specifically have that. Long story short, we use these medications in combination all the time. It's a fantastic combination, a once-a-day pill, a once-a-week injection, very easy to do with kind of minimal side effects.
Let me just say that when they did the studies on reducing heart failure, you got benefits in the first couple weeks. Remember that? Within 4 weeks, the curve of the placebo group started, sagging way below the benefits seen in the group that got the medication. It takes a little longer to reduce heart attacks and strokes with GLP-1s. You know what? And someone said to me, if they could make a liquid form of a SGLT2, you can put it in the once weekly GLP-1 and have them together. Now, Rybelsus is a complicated pill, as you said. It has to be probably by itself, but one of these days you might be popping a GLP-1 and an SGLT2 together.
So speaking of which, someone says, what's your thoughts on Celiqua? And for people out there, Celiqua is a combination of basal insulin, Lantus, with a GLP-1 in one injection. There's also another compound called Exaltify. These names, I know, they're crazy. But basically, if you're on basal insulin, a once-a-day long-acting insulin, there are medications now that put the GLP-1 kind of in it in a combination. So you get one injection, one copay, et cetera. So that's another option.
And it's very effective.
Yeah.
And you titrate it up as if you're just using basal insulin alone on your morning blood sugar.
Yeah.
Super effective. And because you titrate it very slowly, 2 units, a day or 1 unit a day, the GI side effects are very low. The nausea that we see due to the GLP-1 receptor agonists. It's an excellent choice.
So what if you can't afford some of these newer medications?
Yeah, well, I would say this, that ever since COVID started, I think the drug companies are more sensitive to people who don't have enough money to afford the prescriptions.
Right.
So I would check their websites. I would go to our website and click on the logo of those companies that make the drugs. And in there, they have all kinds of programs, patient assistance programs. And there are resources out there also on our website that can help you get a hold of these medications at a fairly low price. And there's even some programs that you don't pay anything for. Right. So we understand that's an issue. And these drugs are lifesavers.
Well, and as you mentioned, I mean, we're calling them newer medications, they are, but for the GLP-1s, they've been out 15 years or so. So there are multiple options that will be covered by Medicare, Medicaid, a lot of the times. And then, some of the SGLT2s might be a little bit harder, but there's copay cards. You have to really have a provider that advocates for you, and then do your own clicking around on websites and things like that. These patient assistance programs, they actually do work. And you can get the medication sometimes for free.
Yeah, and you have to go through paperwork.
Yeah.
But it's worth it. It's really worth it. And if you have any issues at all, then send us a question on the blog, and we see if we can try to get you an answer.
So I'm a type 2 since 2004. A1C is 6.8. On a couple oral medications and Ozempic, a GLP-1, how can I get off all these medications? So
you missed the beginning of the show.
This happens a lot. And the thing is that, you have to ask yourself, why do you really want to get off them? And trust us, we're not trying to keep people on medications, but you have to take whatever you need to keep yourself healthy. If your A1C is 6.8 and your weight's, doing well, I guarantee if you came off these medications, your blood sugars would go through the roof, you'd gain some weight back. So it kind of lends to a bigger question of can I cure my diabetes? And the short answer is really no, unless there's profound weight loss and that's sustained. That this is something that you're going to need to take these medications for to keep yourself kind of healthy. And again, it might be a mental frame shift of, gosh, I have to take these medications versus I'm on these medications that even people without diabetes now are taking and prolonging their life, keeping them healthy. Imagine if these were vitamins. People, get so they're happy to take vitamins because it's keeping them healthy. It's something they think that they're doing that's proactive. Same thing with these diabetes medications. Yeah.
I won't make my joke. You know what? Your question is so important and so common.
Yeah.
And remember that us as healthcare professionals, we don't prescribe drugs. We don't get paid more for doing it. And getting off medication should not be your first goal. The first goal should be get your diabetes, your blood pressure, and your cholesterol levels under control. And then, you can always ask your healthcare professional, do I really need all the drugs on my med list? I know if you have type 2, it could be this long. And trust me, I get this question all the time. Now that we have all these benefits of the SGLT2s and GLP-1s, Jeremy said, if you lost a ton of weight and started running like crazy, you might be able to get off in terms of your glucose control, but you will lose the benefits on your heart and your kidney by stopping those drugs. So the world is a different place now. You're taking these medications, at least the newer ones we're talking about, not even that new anymore, to help prevent the most common cause of passing away, heart disease, and then kidney disease is right there. So try to avoid all those crazy supplements with false promises, that you see on television. Just be real careful about those.
Yeah. Okay. So I'm just scrolling through here. What are your thoughts on Januvia? Reduced my insulin, Tresiba by a half and lost 12 pounds. Not sure why this is happening, not complaining, just wondering what's going on. I've had type 2 for 10 years. So to make this a broader question, about Januvia, which is a fantastic medication, once a day, very easy to take, essentially no side effects. However, it's just not that efficacious. And it has a similar mechanism of action to the GLP-1s. So you never want to be on a Januvia-like medication and a GLP-1. So basically, whenever I see somebody that's on a Januvia-like medication, I try to get them over to one of the GLP-1s that has all these additional benefits. So if it's working for you and you've been on it for a while, great. If your blood sugar is creeping up, it might be time to switch.
Yeah, let me just add something to that. You can check out the next question. Januvia is the first in a class called DPP4 inhibitors, and we have 4 or 5. So we have Januvia, Onglyza, Tradjenta. There's a whole bunch of them, and as Jeremy said, they don't lower your glucose that much. They don't typically lead to weight loss, but they're super easy and there's no side effects. So they do lower the A1C 0.6 to 1%, depending on where you're starting from. That's not chicken feed. So you could actually take it with an SGLT2. Obviously you can't, you're not going to start these things on your own, but I still think they're a very important class of medications.
Yeah.
No side effects.
Any good documentation I can present to my endocrinologist to get on an SGLT2 inhibitor? Stage 3 kidney disease says also type 1, but basically this is a very well-known thing now, that this isn't been in the New England Journal of Medicine, the highest kind of publications we have in the land. Farxiga now has an official indication for treating chronic kidney disease with and without diabetes. So talk to them. If you do have type 1 diabetes, it's a much more not cut and dry, because again, the indication is with or without type 2 diabetes. And where does that put type 1s? It's not indicated for us, but also we think that there might be benefits. So it's a tougher conversation.
Yeah. Well, what you can give to your doctor is type into Google, New England Journal of Medicine, DAPA, DAPA, CKD, and you'll get the ultimate publication of the studies that looked at preservation of kidney, and that you can print it up, and you don't want to shove it in his face, but you just want to say, hey, I was just reading that along with Plenty of Fish or Tinder, and then I saw this article and I thought I'd print it up for you.
I like this. I am O positive blood. I understand this is one reason mosquitoes seek me out. Is my Jardiance another reason? So I don't know. I don't think so. So I guess the idea is that you're peeing out glucose, and maybe the mosquitoes are
they biting the tip of your
your toes? Maybe if you're peeing on the ground. I don't know. This isn't a common known thing.
Yeah, that's I've never heard of that, but thank you for that question.
I wouldn't stop taking your Jardiance because of the mosquito problem. They're annoying, trust me. Whatever happened to sotagliflozin?
Yeah, well, Jeremy mentioned that a little earlier.
That's quite an alarm. You okay, Steve?
My blood sugar's dropping. Real life. Okay, I'm good. 75 diagonal down, but I'll let you know if I need to get some juice. I'll just take off if I do.
Yeah, we're gonna wrap this up.
Yeah, Jeremy's gonna tell me to get over it. My blood sugar's low.
Get over it.
Well, put it this way. A company called Lexicon developed sotagliflozin, very similar to the other SGLT2s, not exactly the same. They went before the FDA, and they said, we'd like to use this in type 1. They showed data. They didn't have any data on heart disease, unfortunately, or kidney. They had some data giving some inclination that they're benefit, but they weren't big enough to prove it with the heart and the kidneys. And because of this episode of diabetic ketoacidosis, and in more particular, you can comment on this when I get done, euglycemic DKA. Oh,
You got some juice. In this diabetes office, we have all kinds of low blood sugar stuff.
Thank you, Eric. Yeah, and that's one of their concerns, that euglycemic DKA, I'll let Jeremy explain it, but at that time, they didn't know the other benefits. They were being very cautious. And these drugs, these SGLT2s are approved in Europe, Japan, and several other countries for people with type 1. What is euglycemic DKA?
Well, I mean, we talked about it. I don't want to beat this up too much, but it's just not,
I'll get over it. Sorry.
Yeah. Drink your juice. What about statins for type 1? Absolutely. Cholesterol lowering medications that we're moving away from looking specifically at the cholesterol number to just that if you are high risk for cardiovascular disease, you should be on a lipid lowering drug. For most people with diabetes, that means if you're over 40. So for everybody with type 1 diabetes, getting your cholesterol down or just being on a statin is a good idea. And if I lose weight, will it return? Well, that depends. A lot of these clinical trials, when people are on these drugs for, let's say, years, the weight does go down and it tends to kind of creep back up. So these aren't, you're definitely still lower than where you started. But if you stop the medications, of course, it'll obviously return.
No, I add a tiny comment to that, is that, these drugs work as long as you take them.
Yeah.
But if you really change your eating habits, your exercise habits, and you can really make those hard changes, and then you continue them after you stop, you might be able to maintain your weight loss.
I like this one because this comes up all the time. Any natural meds that help lower A1C. And again, this is such a big topic that there's just a perception that a natural medication is somehow, better. And honestly, that term has no real meaning to me. That a lot of these drugs came from, these SGLT2s was actually a drug that was found from a type of tree bark.
Is that true?
Yeah, so flozin. So in Metformin, like, these drugs have kind of a history in nature sometimes.
Tree bark is natural.
Yeah, exactly. So, but it's not sold in a drugstore. And trust me, though, these drugs have to go through much more regulation than anything that you could get in a health food store, et cetera. So the short answer is no. People tell you cinnamon or this or that and hope to get off these medications that have gone through all this, extensive testing. So these drugs are these natural things that people will try. Generally, I don't find harmful, but they might just be expensive or a waste of money. So there's nothing that I advise patients that you got to go out and get ginkgo biloba or whatever.
Yeah, you have to get over the natural thing. Honestly, this is your life. This is your diabetes, and you want to be controlled on the least amount of medications possible to get the desired effect with the minimum amount of side effects. And we understand that. We like natural stuff too. We get natural Cinnabons for the cinnamon. No, not making fun of it, but we know you want to live healthy. So,
just going through these. Any relationship between metformin and pulmonary fibrosis? I haven't heard of that. What are your thoughts on metformin, even for people without diabetes? I've read about studies showing lengthened lifespan for people without diabetes. Would you recommend people with type 1 to take metformin? So there's a lot there to unpack. So in general, metformin's been studied extensively in people with type 1 diabetes and generally has no effect. They've actually studied this in terms of blood sugar control, weight loss, and cardiovascular disease, and it doesn't do anything. So we don't really recommend it for type 1s across the table. There is a lot of things out there, like metformin is associated with maybe lower cancer or inflammation or these things. Like, none of that has really been definitive. So it's certainly not anything that we recommend for people in general. The thing that it also has been studied for is, what about people at risk for type 2 diabetes, what we call pre-diabetes, and taking metformin? So,
yeah, it works.
Yeah,
and I was going to say that it does work for polycystic ovary disease, whether you have type 1 or type 2. But in general, I would not recommend taking it. And I also have heard that at these longevity clinics that are out in the middle of the desert, they do give metformin to people. But I wouldn't take it myself.
Yeah. Can we repeat the name of those drugs or show us the packaging? So hopefully, we can put those in the chat, the name of these different medications. But, if you Google GLP-1 or SGLT2, these will come up.
I was just going to say, go to our video vault.
Yeah.
Dr. Tricia Santos and myself have given at least 2 lectures on all these medications.
Yeah.
So TCOID website, video vault, type 2 diabetes, and we go into the details quite well.
Yeah, and then those talks have slides. I mean, we talked about putting these things up, but this is live, so we don't have the capability of doing that. Otherwise, we'd have links and things like that. So please go to the TCOID video vault. There's a zillion hours of free content. You can, and this particular talk is like newer medications for type 2, pictures of the drugs, names, all that. It's worth just at least scrolling through. I've been using Jardiance along with Metformin and insulin via a pump. I lost about 40 pounds when these drugs were added. Need to lose additional weight, thinking of going to Jardiance 25. Are there any specific adverse effects of 25 versus 10? So that's a good question, because the SGLT2s all generally come in 2 different doses, and the GLP-1s you have to titrate. For the SGLT2s, for me, I put all the type 2s on the higher dose. It tends to be slightly more efficacious, the same kind of copay and things like that. So that's what I do.
And you know what? When you look at the long list of side effects on these doctor slides that we get, they're no difference.
Yeah.
So I always start with the highest dose as well. I mean, the only time you want to start with the lower dose if you are elderly or you are on a very strong diuretic, but that's probably too much information. They're both doses are very safe. Now, in terms of losing more weight, really you're probably not going to lose any more weight going from the low dose to the high dose, just to be honest. And you'd have to go to other measures, and perhaps high dose GLP-1 receptor agonist, got to talk to your doctor.
Why do some of these drugs cause pancreatitis? So this is a good question. So pancreatitis is an inflammation of the pancreas that can cause severe abdominal pain. And years ago, there was this debate if GLP-1s cause pancreatitis. And long story short, that's been put to rest, that these drugs do not cause pancreatitis. So that being said, if you're somebody that's had recurrent bouts of pancreatitis and you don't know what's going on, it's probably not a drug that I would throw into the mix. But I don't know, what do you say?
I want to add to that. The very first GLP-1 receptor agonist, Byetta, now it's once weekly Bydureon, that was way back in 2006. So when they first published it, there was a few more people that had pancreatitis. So it got into the official package insert, and there's a warning for it. So then, as you mentioned, big debate's over. There's an association with pancreatitis and type 2 diabetes, but what we call, there's never been a direct cause and effect relationship. And we know that people with diabetes have 3 times the higher rate of pancreatitis than people without type 2 diabetes. We know it's associated with obesity. And to be honest, as Jeremy said, if you've had pancreatitis from drinking too much alcohol, or because your triglyceride or cholesterol levels are too high in your blood, that shouldn't stop you from taking a GLP-1. But if you've had a bunch of episodes, and us doctors call it idiopathic, like we don't know why, it's just safe to stay away from it. Because even as a caregiver, people will give you grief if they say, why'd you start it in that patient? I don't believe there's any direct cause and effect, but that's me. And I date a woman who's a high-powered lawyer. She usually protects me in court.
Usually.
Usually.
This was just, I think, a general question. It says, ask for both overweight type 1 and type 2, which of these medications would be a good option? Again, the SGLT2s and GLP-1s, the one caveat there is that these GLP-1s, these higher doses are the newest thing, and they have different names. So to be specific, you've heard of Ozempic, which we use for diabetes. At higher doses, it's called Wegovy. It's the same exact drug, but it's the same exact molecule, but it's given a different name because it has a different indication. So you might ask your provider about not just a GLP-1, but if you can be on one of these higher dose ones.
Yeah.
Same thing with Trulicity.
Trulicity, yep. And Victoza.
Victoza, yeah. If you really want to kind of put the pedal to the metal, specifically for weight loss.
And if you look at all the clinical studies of weight loss with GLP-1s versus SGLT2s, the GLP-1s do lead to greater weight loss in general.
Yeah.
So that's important to know.
And 2/3 of type 1s are overweight or obese. So if you're a type 1 struggling with your weight, you are the majority. And I have had some success getting some of these weight loss GLP-1s approved for people with type 1 diabetes, specifically for the weight loss indication. And it generally does help improve blood sugars a little bit. People use less insulin, et cetera. So that's a potential way to approach this, if it specifically is for weight. So you're seeing that these drugs, because of all the different effects, they can be used in different kind of places.
Yeah, yeah. And you know what? A lot of folks with type 1 diabetes also have the tendency for type 2 and vice versa. You know, sometimes if, for example, you might have someone that has type 1, but both their parents have type 2. They've always had problems with weight. They also have some other things that are associated with type 2, like high triglycerides or hypertension. So you can have a thing called hybrid diabetes. And that's what I do when I request it from the insurance company. I say this patient has both type 1 and type 2.
Yeah.
Tell your doctor about that trick.
Insulin resistance is something else you can just say, which is true. Yeah. Everybody with type 1 diabetes has some degree of insulin resistance. So I think we can kind of wrap it up. I mean, we can answer any other questions. Maybe, I don't know if we send out answers or how we do that.
We'll respond to all the answers later on that weren't answered.
But I think,
the questions that
you know, hopefully the thing that you're getting hit over the head with is there's a zillion options, and there's some good options. So if you've been on something for a long time, or actually it's irrelevant how long you've been on it, just make sure that you're seeing a provider, somebody that knows kind of these new options. If they're not bringing it up with you, you bring it up with them. Hey, I heard about these new medications that cause weight loss or whatever. Is that something that I should try? And see what they say.
Yeah, some of your doctors are able to store samples. Mm-hmm. You know, big universities, they kind of push people away from holding samples, and you can always try it. You know, you can get like one of these GLP-1s, and they can give you enough for at least a month and see if you can tolerate it, if you like it. And I would just say that, you know, go to our video vault, learn about these drugs in detail before you go to your doctor.
Yeah.
You want to be an educated consumer and to have a conversation with him or her. So it's really important for all you type 2s out there to really know as much as you can about these two new classes of agents. And for you type 1s with kidney disease, weight problems, also the propensity for heart failure, for sure you need to talk to your doctors about these drugs. So it's a whole new era.
I got to throw in a plug too. If you've enjoyed this program, you can also donate on our website. We always really appreciate it. And if you donate, there's a good chance, I'm not kidding, that Steve will give you a call and say thank you.
Definitely.
We really
call you
appreciate
personally.
it.
I don't care how much you gave or give.
Steve and I are going to hang out. How's your blood sugar doing?
It's still going down. Maybe I should get low more often during these.
He's making sense, and I'll take care of him, everybody, so don't worry. All right, everybody, have a good night, and we'll hopefully see you soon.
Thank you. That's fun.